In the previous section, we discussed some of the social and secondary effects of TBI. In this section, I would like to explore in more depth neuroendocrine dysfunction. This is a widespread but little-known aspect of TBI. The secondary cascades of neurodegeneration in many cases lead to neuroendocrine dysregulation, or NED. Chronic hormone deficiencies occur in 30 to 40% of TBI cases. 10 to 15% of these cases involve more than one deficiency. Up to 30% develop hypothyroidism and adrenal deficiency, which is very common. 15% develop gonadal hormone deficiencies. 30% show elevated prolactin levels. And is now recognized that up to 80% of adult growth hormone deficiency is likely due to TBI. Even mild TBI, or what we refer to as everyday head bumps, can have consequences. Approximately 15% of patients with mild TBI experience persistent symptoms. Of the approximate 15% who experience a mild TBI and remain symptomatic, an estimated 15 to 30% go on to develop NED. The majority of the symptoms are related to pituitary and thyroid dysregulation. Here is a list of the hormones typically affected: FSH, GH, IGF-1, LH, and TSH. Here in this slide is a more detailed representation of deficiency symptoms that can occur. Deficiency symptoms due to TBI are quite varied and complex in presentation. They can include significant changes in weight, mood problems, decreased libido, insomnia, decreased energy, memory problems, and many other areas, as you can see. It is not uncommon for IGF-1, which involves the regulation of glucose in the brain, to become depleted as a consequence of TBI, leading to impaired neuronal, somatic, and dendritic growth. NED can be difficult to distinguish from post-concussive syndrome. Post-concussive syndrome typically involves headache, dizziness, blurred vision, sleep disturbances, sensitivity to light and noise, balance problems, memory deficits, slowed processing, impaired judgment, altered executive function, agitation, irritability, impulsivity, and aggression. NED, on the other hand, typically involves loss of libido, infertility, amenorrhea, loss of muscle mass, increased belly body fat, low blood pressure, reduced heart rate, hair loss, anemia, constipation, cold intolerance, and dry skin. Yet together, these share fatigue, poor memory, anxiety, depression, weight gain or loss, emotional lability, lack of concentration, and attention difficulties. One aspect of NED that can be used to distinguish between post-concussive syndrome and NED is the persistence of symptoms. If symptoms persist beyond 3 months, then NED is likely present. As we have mentioned before, the incidence of TBI and NED is far greater than most professionals realize, and is far greater than MS, HIV, breast cancer, and spinal cord injuries combined. In a 30-year follow-up study on TBI cases, 48% were found to have axis 1 problems, 27% depression, 12% alcohol abuse, 8% panic disorder, and 8% phobias. 23% demonstrated axis 2 features. As we mentioned previously, PTSD also frequently accompanies TBI. While TBI involves headaches and sensitivity to light or noise, nausea, vomiting, vision problems, and dizziness, PTSD involves flashbacks, avoidance, hypervigilance, nightmares, and re-experiencing of the phenomenon. Together they share irritability, cognitive deficits, insomnia, depression, fatigue, and anxiety. This is a qEEG of multiple subconcussive events from auto accidents involving NED and PTSD. Axis 2 symptoms were emerging as well. Note the regional deficit of delta reducing working memory function, compounded by reduced midline theta, which also affects memory search functions. Posterior elevated alpha typically involves perseverance issues, while globally elevated beta indicates anticipatory anxiety, panic disorder, and severe rumination. This client presented with all of these features. Again, it is important to remember that qEEG patterns can vary considerably based on the intensity of the trauma and whether or not NED emerges. The TBI case below the one above in this slide shows global delta loss with elevated global theta, frontal beta deficits, and slowed alpha. A very different pattern with its own unique consequences. The NewMind Cognitive Emotional Checklist is very valuable for initial screening of symptoms. These symptoms can be confirmed by the qEEG and then again by having the client take the NewMind computerized performance tests, which clients can also take at home. These tests are quick and easy and based on decades of research in memory processing and attention. The individual in this case reported severe symptoms across all dimensions of attention, memory, impulse control, depression, and anxiety. This is indicated by the red values under category score. As noted in the predicted map to the left, based on symptom report, the likely consequences are going to be quite global. The NewMind metabolic analysis becomes very useful and important to reference in these cases. This questionnaire reviews symptoms and their severity and then aggregates them into metabolic categories. This instrument has been normed with an N of 3,000 from over 500 clinics across the country. Very elevated symptomologies appearing in this case related to pituitary function, kidney function, adrenals, and thyroid all point to possible involvement of NED. In addition, blood sugar regulation appears affected, as well as gastrointestinal and liver function. This client also had gallbladder and somatic symptoms related to anxiety and PTSD which were present. This is likely a case of NED since these symptoms were more than a year old, and this individual was still in their late 20s. As you can see, TBI is a complex phenomenon for neurofeedback practitioners to deal with. It may involve PTSD and NED. This requires referral to other competent professionals knowledgeable in these areas who can cooperate effectively to assist the neurofeedback training process. Neurofeedback training should not begin for at least 2 to 3